Hello, I'm Dr. Michael Moritz. I'm a professor of pediatrics at Children's Hospital of Pittsburgh. I'm the clinical director of pediatric nephrology, the medical director of pediatric dialysis in the kidney transplant program, and I'm also one of the members of the Center for Rare Diseases in Children that has invited me to talk. And I'm going to be talking about case studies in primary hyperoxaluria. It is a ultra orphan disease, which leads to very serious kidney stones. In terms of the objectives, we're going to review a pediatric kidney stone disease. We'll do an overview of that. We'll talk about the different causes of monogenic nephrolithiasis, and then we'll go into primary hyperoxaluria, and we'll present some various cases. In way of disclosure, I have received honorariums for both speaking engagement and consulting fees for clinical research by Alnylam Pharmaceuticals. They are the maker of Oxlumo, which is a recently FDA-approved therapy for primary hyperoxaluria. By way of introduction, I was probably one of the first people to enroll patients with primary hyperoxaluria in the clinical trials for Oxlumo, which is how I sort of became an expert in this topic. And I've had multiple patients with it. I'm going to be presenting 3 of those patients, so I have, familiarity with this pretty new therapy. So diving just right into, pediatric kidney stone disease. Kidney stones are common and they have morbidity associated with it. Approximately 1 in 11 people will develop a kidney stone at some time in their life. Most people who have a kidney stone will have recurrent kidney stones. About 50% will have a stone within 8 years, and a significant number of patients will have 2 or more kidney stones. And in addition to being, significantly, painful, they do damage to the kidney, can contribute to hypertension, type 2 diabetes, obesity, heart disease, metabolic syndrome, and the development of chronic kidney disease. So what causes kidney stones? It's pretty complex, and we have a lot to learn about what causes kidney stones. We do not know all the factors, but it is a multifactorial process that leads from excess crystal formation. Stones can be calcium oxalate, calcium phosphate, urate stones, and basically the way kidney stones are, let me turn the pointer on, broken up is from hypercalciuria, hypocitraturia, hypouricosuria, cystinuria, and hyperoxaluria. Though many times when we do a full evaluation, about half the time, you will not find a cause for the kidney stones. In terms of presenting symptoms of pediatric nephrolithiasis, in older children, the symptoms are pretty similar to adults, with flank pain, gross hematuria, nausea and vomiting, urinary tract infections, abdominal pain, groin pain, dysuria. In younger children who don't get kidney stones very often, it can be a lot more difficult to diagnose. They can have irritability, inconsolable crying, poor feeding, vomiting, diarrhea, urinary tract infections, abdominal pain. So when a pediatric patient presents with a kidney stone, you need to do a full evaluation, because in pediatrics, different than adults, there can be a lot of secondary causes that could contribute to the stone. So you want to look at their growth and development. If they have poor growth and development, they may have renal tubular acidosis, or they may have a genetic syndrome. The same thing with poor bone development. Also with blood pressure, if there's a hormonal disorder, a history of prematurity, if there's a congenital anomaly of the kidney and urinary tract that causes stasis, if they have immobilization or fractures, if they have gastrointestinal disorders, which could lead to intestinal hyperoxaluria, which we're going to talk about. And you want to assess if there's any medications that would increase stone risk. So 2 things to really know about is Topamax and Zonogram. Those are pretty common seizure meds in children, and in children they use Topamax for migraine headaches, and they can cause really severe kidney stones, so you have to know about it. Fluid intake and dietary intake. So if there's any special diets, which we're going to go down here, like a ketogenic diet causes kidney stones. Protein intake, salt intake leads to hypercalciuria. Other vitamins in supplements, which might be high in oxalate. Almond milk, if you drink a lot of almond milk has a very high oxalate concentration. So family histories, stone formers are more likely to have a first-degree relative with kidney stones. So if there's a family history, that's important. Hypercalciuria is found in 50% of first-degree relatives. 40% of children with urologitis have a family history of kidney stones. If there's a history of consanguinity, which increases the risk of an autosomal recessive disorder for kidney stones. Cystinuria and primary hyperoxaluria type 1, which we're going to talk about, are really the main inheritable conditions of kidney stones in children. If there's a history of kidney stones, renal failure, and proteinuria in the family, that could be a sign of a rare condition called dent disease. So once you go through the history, in terms of the lab evaluation, first starts off by getting a urinalysis, looking at the urine pH. A very high urine pH can lead to phosphate stones, a low urine pH to oxalate stones. If there's hematuria, pyuria, proteinuria, bacteriuria, glycosuria, looking at the urinary sediment, which can give you a clue of what type of kidney stone you might have. And then biochemistries, looking at the sodium, potassium, chloride, total CO2, blood urea nitrogen, creatinine, calcium, magnesium, phosphorus, uric acid. The main thing, there's many things it can pick up, but if there's hypercalcemia or acidosis, those would be the two main things for most patients. Though with more rare forms of kidney stones, there could be other metabolic abnormalities. In young children, you can do a spot urine for calcium to creatinine to look at hypercalciuria, citrate for hypocitraturia, oxalate for hyperoxaluria, and uric acid for hyperuricosuria. In older children, you can get a much more detailed analysis by doing a 24-hour urine collection. The typical stone profiles include volume, calcium, creatinine, citrate, phosphorus, pH, sodium, urea, oxalate, chloride, ammonium, magnesium, potassium, uric acid, sulfate, and then cysteine to pick up cystinuria. Most of the 24-hour urines, on the first time they do a panel, it will include a cysteine just to screen for cystinuria, and then it will not be included in subsequent panels. So what does all of this look for? What can it can rule out hypercalciuria, hypocitraturia, hyperoxaluria, hyperuricosuria, cystinuria, which will have high urine citrate, renal tubular acidosis, and hypercalcemia. So those are the main things that we are excluding. In terms of urinary crystals, these hexagonal crystals are the classic crystals from cystinuria. And this picture is not the greatest. So typical oxalate crystals are very, pretty marquee diamond shape. This isn't, a great, picture of that. But these dumbbell crystals are the calcium monohydrate, and that's what you see. We're going to talk about this more. What you see with primary hyperoxaluria versus idiopathic, hyperoxaluria with oxalate dihydrate, and these are amorphous crystals. Oh, I did meant to say, if you have any questions, just go ahead and ask them throughout the talk. We have a moderator who's moderating the question, and he will feed them to me, so don't feel that you have to hold the questions to the end. Anything that comes up, please pass it on to the moderator. So these tests are not routine. So these tests you really want to do if you think there's, an unusual form of kidney stones. So 25 and 125 of vitamin D could be helpful in certain syndromes that lead to kidney stones. So, idiopathic infantile hypercalciuria, if there's hyperparathyroidism, if we think there's hypercalcemia and ionized calcium. So urine amino acids can be a really helpful screening test. So if you're concerned about cystinuria, and then maybe you have a child and it's difficult to get a 24-hour urine, or it can be time consuming, or it can be difficult for them to collect it, you can just send urine amino acids, and the acronym of the amino acids you'll see in the urine is COL: cysteine, ornithine, arginine, and lysine. If those are positive on a urine amino acid profile, that's suggestive of cystinuria. Also with PH1, it can take a while to get oxalate levels back. In PH1, there will be a glycolate peak, so there'll be glycolate and glycerate. Now this isn't super sensitive, but if you do see that, it's suggestive. And now genetic testing is much more available, it's much less expensive, and it can be extremely helpful in young children with kidney stones or recurrent kidney stones. So we'll go through a case. This is a patient who we just saw in the last year, and it was quite an interesting case. It was an 8-year-old male with no past medical history who presented to the emergency department with 1 day of vomiting. He had chills and a fever. He had left flank pain, left lower quadrant pain, dysuria with pain at the tip of the penis, and within 24 hours he had passed 12 kidney stones. Due to this really concerning history, we did a genetic testing, a kidney stone analysis, and plasma oxalate was sent. The initial blood work which we had at the time showed that the child was in kidney failure. Remember, no past medical history whatsoever, creatinine 2.38. The rest of the testing was normal. The urinalysis had some pyuria, moderate leukocytes. There was no hypercalciuria. In fact, the urine calcium was undetectable. The urine amino acid profile was normal, so there was not a glycolate peak. And we were also considering dent disease, so we sent a urine beta-2 macroglobulin, and it was really high. When we did imaging, there were multiple non-obstructive calcifications, and very important, there was nephrocalcinosis. If ever you see nephrocalcinosis in a child, that raises a red flag of a genetic stone disease. Most idiopathic stone formers do not have nephrocalcinosis, and there was debris in the bladder. So this is the ultrasound, and you can see the kidney stones and the nephrocalcinosis. You can see the shadowing, of these calcifications. This is called a twinkle artifact. Sometimes you can't see the shadowing, but the sound waves will leave this twinkle artifact. It can be helpful, not always. You can see the significant debris, in the bladder. These weren't necessarily bladder stones. He was able to pass this debris. And then you can see, the significant, kidney stones and nephrocalcinosis on CT scan. And you can even see the kidney stones, really nicely on a plain film, which you don't always see in a pediatric patient. And the child ended up having primary hyperoxaluria type 1. The stone was sent for analysis. This came back first, and it was 80% calcium monohydrate. That's a tip-off that you're dealing with PH1. If you send a stone for analysis and it's primarily calcium monohydrate, that is very concerning for PH1, whereas most kidney stones are primarily calcium dihydrate. He had an elevated plasma oxalate level, which is really concerning. That pretty much only happens if there's a reduction in GFR. And the genetic testing came back with two pathogenic variants. He inherited a mutation from each of his parents. For PH1, we did a 24-hour urine, and it showed very high urine oxalate. If it's greater than 100 milligrams per 1.73 meters squared, that's suggestive of hyperoxaluria. There also happen to be hypocitraturia, but mainly very high urine oxalate. So PH1 is an inherited inborn error of metabolism, specifically of hepatic enzymes, which results in overproduction of oxalate. Oxalate is excreted in the kidneys with hyperoxaluria. They cannot all be excreted, and it leads to kidney stones on ultrasound, nephrocalcinosis, chronic kidney disease, and in some cases end-stage renal disease. And you can see how fast this progressed. This child was normal within a short period of time. He was in kidney failure. So a practical tip, in PH1, the stones are not usually calcium dihydrate. They're usually calcium monohydrate. So going to genetic causes of kidney stones, monogenic causes of kidney stones can be found in about 11% of adults and 20% of patients less than 25. I found this surprising, but once you start looking for it, you start picking up some variants. Chronic kidney disease is a complication of kidney stones, especially in the genetic disorders and especially in PH1 and cystinuria. So when you're looking at monogenic causes of nephrolithiasis, they can be broken down based on the urinary findings, which we spoke about. There's cystinuria and hyperoxaluria, which are the two most common type. And then there are various hypercalciuric forms with or without disorders in serum calcium. So you can have high or low serum calcium, you can have low phosphorus, hypomagnesemia, hypokalemia, acidosis, disorders in PTH, potentially high 125 vitamin D, nephrocalcinosis, which is very common. There can also be syndromic features or bony abnormalities, hypocitraturia, which is mainly from renal tubular acidosis, and then disorders of purine metabolism with either hyperuricosuriya or xanthinuria. So tip-offs that there's a genetic cause of kidney stones. Consider genetic testing if it's early onset. Frequently, we have children who are following in the nephrology clinic for nephrocalcinosis, unexplained incidental finding. They should have genetic testing done. If there's a strong family prevalence, consanguinity, and if they're unusual, if there's multiple recurrent or large stones, that is a clue that there's a genetic disorder. Nephrocalcinosis is a tip-off. Laboratory studies that suggest further evaluation, and the early detection can lead to tailored therapy that could potentially prevent the development of chronic kidney disease, end-stage renal disease. A delay in diagnosis can lead to morbidity. So, well, what genetic disorders are we talking about? So these are some studies from a stone clinic who had patients who did not have an identifiable form of kidney stones, and they subjected them to genetic testing. And these are the different diagnoses based on age. So idiopathic infantile hypercalcemia is primarily in those infants that have hypercalciuria. I'm sorry, nephrocalcinosis, you don't know about it. Bartter syndrome, primary hyperoxaluria type 1 or 2, hypercalciuria, RTA, hypomagnesemia with ocular disease, different disorders of nephrolithiasis, cystinuria. So these are the different types of rare conditions that you can see in those patients. And now we're going to move on to primary hyperoxaluria type 1. So hyperoxaluria is excess urinary oxalate, and it can be primary, which we're talking about. So this is a rare autosomal recessive disorder from genetic mutations that result in hepatic overproduction of oxalate. Primary hyperoxaluria type 1 is the main and most severe cause, happens in about 80% of cases, but there's also hyperoxaluria type 2 and type 3. And then there's secondary hyperoxaluria, which can be idiopathic, increased dietary or intestinal oxalate, excessive precursors, alteration in intestinal flora. So enteric hyperoxaluria, which typically is due from an intestinal disorder, if there's a fat malabsorption, if there's if there's cystic fibrosis, Crohn's disease, short gut syndrome, the fat malabsorption leads to the fat binds calcium, and calcium binds oxalate. So when you have fat malabsorption, that binds the calcium can't bind the oxalate, so you have hyperabsorption of oxalate and hyperoxaluria. Also, fat malabsorption increases intestinal permeability of oxalate. Certain foods are specifically high in oxalate, rhubarb, which I don't know if that's particularly common, but chocolates, different green leafy vegetables, teas, and idiopathic, which we don't really, just some people have hyperoxaluria. So primary hyperoxaluria is from, a hepatic disorder. It's, an ultra orphan rare disease. It's probably a little bit underdiagnosed, but about 1 per 120,000 live births. The prevalence is about 1 to 3 patients per million population. There are certain areas where there's higher prevalence. There is some variation, and again, it can be likely underdiagnosed. I'm going to present a patient of mine who I had missed the diagnosis for many years, actually. So it is a disorder in the alanine glyoxylate aminotransferase enzyme, and that converts alanine to pyruvate and glycine, and by that enzyme being deficient, the glycine goes to glyoxylate and then goes to oxalate and glycolate, and it's the glycolate oxidase that converts that. So that's sort of important to remember, that the glycolate oxidase converts that step. That leads to overproduction of oxalate, which is insoluble, and leads to oxalate crystals, not just in the kidneys, but throughout the entire body. It is a systemic disease. That's called systemic oxalosis. When the GFR decreases and the plasma oxalate level increases, so first you get stone formation, which leads to renal failure, which leads to high plasma oxalate level, which leads to systemic oxalosis, which is very serious. And because there's glycolate, you can potentially pick up that glycolate peak. The natural history of primary hyperoxaluria type 1. The age of onset can vary from less than a year of age, that's the infantile type, to greater than 16 years of age. Most symptoms begin before age 10, vast majority before age 20. Just like most kidney stones, you can have hematuria, abdominal pain, urinary tract infection, dysuria, stone passage. Some patients, and we're going to present a case, can have a really severe disease. Infants can have failure to thrive and end-stage kidney disease in infancy. And symptoms of diagnosis can range from just being, pre-symptomatic to life-threatening. And PH1 is the most devastating type, especially the infantile type. We'll present a case of that. Diffuse nephrocalcinosis is noted in about half of patients. So when you see that, that's really concerning. Majority of patients will eventually progress to end-stage kidney disease if left untreated. There is a progressive decline in renal function over time. By about 20 years of age, 20% of the patients will have end-stage renal disease. About 30, when it says, 43% by age 49, 90% by age 60 will have end-stage renal disease. So it progresses, over time. And it is a systemic disease. So as the GFR declines, the plasma oxalate increases. and it deposits in tissues throughout the body. So eye exams are necessary. It can cause visual disturbances. It deposits in the blood vessel, which can lead to, ischemia, cerebral infarction, cutaneous ulcers, deposit in the joints with synovitis, reduced mobility. It deposits in the bone marrow and can cause, refractory anemia and bone marrow failure, hypothyroidism, dental disorders. It causes cardiac deposition with heart block and cardiomyopathy, peripheral neuropathy, and then an osteodystrophy with bone pain and fractures. So even if a patient is on dialysis, we're going to get to this, they need intensive dialysis to prevent the systemic oxalosis. So the diagnosis of PH1 is often delayed. The mean time of diagnosis is 5.5 years. Part of the reason for the delay is just a low index of suspicion, people not being familiar with the condition by not seeing it because it's so rare. They may have limited access to doing a metabolic evaluation or genetic testing for this. So the worst type is the infantile type, and they are present in the first couple of months of age. It's the most severe, and it can progress to end-stage renal disease very quickly. The pediatric diagnosis, which we're going to present a case of, the median diagnosis is about 1.3 years. That's about 50% of the patients, and then the adult type is in about 28% of the patients. Mean time to diagnosis 9.2 years. So the case that I just presented was the adult form, and he presented at 10 years of age. So case 2 is the very early onset infantile case. And this is a case which I personally managed. This child at 8 months of age had failure to thrive with many weeks of recurrent vomiting. The child was diagnosed with gastroesophageal reflux, was placed with Prevacid. The vomiting continued to persist. 4 times daily. There was hematemesis, decreased urine output, and then he ended up having a GI evaluation for this. And on the upper GI, there was an incidental finding of bilateral nephrocalcinosis that prompted to lab evaluation. Now the child had a BUN of 191 and a creatinine of 10.3. Emergent dialysis was started. It was not at our center. The child was transferred to us. They started with peritoneal dialysis. The plasma oxalate level came back, which was extremely elevated. Molecular diagnostic testing did confirm PH1. Intensive hemodialysis and peritoneal dialysis was started. And the reason why you have to be very intensive is because if you don't, you will have systemic oxalosis, and even if you do a transplant, even if you do a liver and kidney transplant, if the oxalate load is too big, you can still get kidney stones and you could still go into renal failure. So you really have to do intensive dialysis to remove it. This child had a deceased donor liver transplant at 14 months of age when he was 10 kilograms. It had many complications: delayed abdominal closure, hepatic artery thrombosis, biliary stenosis, acute cellular rejection. That was followed by a living donor kidney transplant at 16 months of age, which had numerous complications, rejection, viral infection. So these are really, really challenging patients to manage. And this child is now a teenager and doing well. So there is genetic testing available for this. Target mutation analysis is typically all that is necessary. We'll pick up most cases. If that does not do it, whole gene sequencing is available. Prenatal testing can be done. And the prognosis depends on how early it is picked up and how aggressive is the management. And the main management is you really up until just recently was hyperhydration. Again, most patients will progress to kidney failure. That infant mortality of that infantile type was actually quite high. Our center, had the expertise to do, a liver and kidney transplant in a very small child. So, so strategies to, prevent kidney damage and to slow the progression of the kidney disease is pretty much, hyperhydration, agents that present precipitation, and then, surgeries to deal with the kidney stone complication. So, hyperhydration, many of these children might need G tubes or need to be woken up in the middle of the night to drink. Alkali therapy with potassium citrate can present calcium oxalate saturation. Diet plays a minimal role. Pyridoxine can be helpful. Many of the hepatic enzymes can be induced by pyridoxine. We're going to present a case with that. And they really need frequent and intensive hemodialysis, 6 days a week, plus peritoneal dialysis, nocturnal dialysis if it's available in an older adult. And prior to some of the newer therapies, you really had to do a combined liver and kidney transplant. The liver transplant will introduce the proper enzyme to metabolize oxalate, but it's not going to clear the oxalate that's already deposited in tissues. Preemptive liver transplant can be done. That can be challenging to do that in a patient who's doing okay. And an isolated kidney transplant will replace kidney function, but it does not solve the disease, and they can require multiple kidney transplants. Patients with PH1 need lifelong, surveillance for complications. If the GFR is good, then it's sufficient to watch kidney function and get renal ultrasounds to look for stone formation, periodic fundoscopic exams, and just checking urine for oxalate. Once the GFR declines, though, if the GFR is good, the kidneys can clear the oxalate. Once the GFR declines, the plasma oxalate starts increasing, so you need to start measuring plasma oxalate levels. When the GFR decreases significantly, then the plasma oxalate level will get so high that now you're going to start getting depositions, and now you need to start looking for all those symptoms of systemic oxalosis, which we spoke about. And really, fortunately, there is now, this is really just a devastating disease, and now we really have a good therapy. Lumasiran is a currently FDA-approved therapy, but there's other therapies. So these are interfering RNAs, which we'll talk about. Oxlumo is the first FDA-approved therapy, but there's other ones in the pipeline. So there will be, choices to manage these patients. So what we said was that the glycolate oxidase is what leads to the oxalate production. So lumasiran targets the hydroxy acid oxidase, which encodes GO, and it decreases the production of that enzyme, which then results in decreased production of oxalate. So, and I'm going to present you a patient who had the pediatric form. This was a 2-year-old male who presented with vomiting and was diagnosed with GERD, treated with Prevacid. He developed acute abdominal pain, was suspected to have appendicitis. And then he had a CT scan which showed multiple stones with a right obstructive urolithiasis. A laser lithotripsy had 60% calcium oxalate monohydride. we didn't quite really appreciate the seriousness of this at the time. We had a presumptive diagnosis of pyridoxine responsive PH1. He required 7 lithotripsies over 7 years. We tried all kinds of therapies to decrease his stones, thiazides, potassium citrate, probiotics, pyridoxine, hydroxycitrate. And by 11 years of age, he started having a decline in renal function. Free genetic testing was available, which we availed ourselves of. He ended up having a period. He did have this mutation can be induced by pyridoxine. So he did have a pyridoxine sensitive PH1 as we suspected, and he was like one of the first patients enrolled in the clinical trials, which we're going to talk about. And he did really well. We have lots of 24-hour urines on him, and his response to pyridoxine was variable. It wasn't consistent. Sometimes it was good, sometimes it was not, and that can happen. And he had variable levels of oxalate in his urine. These are the pictures of the calcium oxalate stones which he had. He passed many of them. They're yellow. So, Oxalumo is the FDA-approved therapy for this, and they've had 2 trials. We'll just go over them briefly. There was the Illuminate A trial, which was in children greater than 6 years of age, and the recently published, I think it was just published this year, the Illuminate B trial with children less than 6 years of age with relatively well-preserved GFR. This is a double-blinded, this is open label. And the main thing that we're looking at is the change in urinary oxalate. It was a 2-to-1 randomization, but then after a blinded period, they all went to open label. Average age was 17 years of age. Patients had relatively preserved GFR. Some of the patients were on pyridoxine, and it results in around a 75% decrease in oxalate. So it works, within a couple of months, it works really well, and it keeps a sustained reduction in urine oxalate. The levels are pretty much, near normal for a significant percent of the patients. So, 60%, 65% reduction in plasma oxalate. 84% of the patients, their levels were within 1.5 times the upper limits of normal. 84% were within normal or near normal range. 52% were within the normal range. And the main adverse reaction, and I've seen this, is the injection site reactions. I've had patients complain about this. The other, there's really not a big difference between placebo and controls for abdominal pain, headache, rhinitis, whatnot. So really the main adverse reaction is the injection site reaction. So Illuminate B was open label, so basically all the children got treated, and these were in children less than 6 years of age. So there were 3 children less than 10 kilograms, 50 children 10 to 20, so this is more the pediatric form, and then 3 children greater than 20 kilograms. They had relatively preserved GFR. That's part of the inclusion criteria, that they had a GFR greater than 30. And it led to a 72% reduction in oxalate, 84% for children less than 10 kilograms, about 70% for children greater than 10 kilograms. And you can see, a really nice reduction in urinary oxalate. And the main, reaction is primarily, injection site reactions. So the dosing, this is really from patient convenient, it is really an attractive medication for the vast majority of patients, who are greater than 10 kilograms. It's a subcutaneous injection monthly for 3 months, and then every 3 months thereafter. For children less than 10 kilograms, it's dosed monthly. So, and every 3-month injection, and it works really well. So that's really a really convenient and attractive dosing. So, in summary, it's important to know the cause of the kidney stone. So in children, it's important to do further evaluations. It's important to do, a full evaluation of stones with a stone analysis, 24-hour urine. Monogenic causes are probably more common than you think, and there's probably patients that you may have that could benefit from genetic testing that you didn't consider. Again, the tip-offs are if there's nephrocalcinosis or frequent recurrent stones or multiple stones. Genetic testing, can lead to a quicker diagnosis, more appropriate therapy, and can help you diagnose family members that are unrecognized. PH1 is one of the most common forms, monogenic forms of end-stage kidney disease. Also, really the most serious that can lead to end-stage kidney disease. And fortunately now is really the only treatable form now that we have these interfering RNAs. So I will stop at that. And if there's any questions in the chat, I will answer them. Okay. Moderator, are we good? All right, very good. Thank you so much.